and joining us shortly, but we'll make a start so we don't run over time. So welcome everybody to this session. Today's session will be a focus on children's needs for palliative care. And we will, Megan will give a short teaching, and we'll have some time for discussion and questions after that teaching. And then we'll have a case presentation, and Rachel from MSF and Dr. Junaid will present the case today, and we will have discussion time after that. So as always, please do feel free to write your comments and questions in the chat. We will be following that as we go along, and you can write in English or in Bangla. We have Bangla faculty who can answer in Bangla as well. And just keep yourself on mute unless you're asking a question so that it doesn't affect the quality of the sound. So I'll now hand over to Dr. Megan, who will give us an introduction to pediatric palliative care. Thank you, Megan.
Thank you, and good morning to you all. Very nice to see you. Many of the people who are in the first echo this morning, and again, you're going to hear more about pediatric palliative care. And so this is a summary of the video that Dr. Natasha had prepared that we shared with you, the link on pediatric palliative care. We're going to talk about what is children's palliative care, when we start it, which children can benefit, and a few tips about how you actually do the care. So I think one thing to emphasize is that we really want you to take up this idea that palliative care, there is a new model, especially for children, and that model is that we start palliative care early in the course of the illness, and we increase the palliative care as needed as we go along. So here the idea is the dark blue is palliative care, and the sort of whitish gray is treatment that might help with the disease, so disease modifying or disease directed treatment. And you can combine these. The child gets diagnosed at the beginning here on the left, and you can give a little bit of palliative care for their symptoms, but they're taking maybe treatment for their cancer. And then as time goes on, initially your goal is to cure their illness or control their illness. But if it progresses, then you might need more palliative care because they're going to have more symptoms. Family's going to be more stressed. And so the blue is going to increase as you go along towards the right side of the page. And you have disease progression perhaps. And then they enter what we call the end of life care phase, or the terminal phase of the illness, which refers to typically the last few weeks of life, when it's very clear the person is coming to the end of their life usually, especially for children with cancer, it's more clear. And here your really primary mode of treatment is palliative care, symptom management, focusing on supporting the child and their family in the location of choice. And then after the child dies, we can also still give some palliative care in the form of bereavement. Bereavement means care for the family after the child has died. And normally how we do that for children in settings like the Rohingya camps is a phone call 1 or 2 weeks after the child dies to check on how the mother and the father are doing, maybe a visit from a CHW to just give some support, say, you know, how are you managing now that your child's passed away? And people find that very supportive. Families find that that's very supportive. Even though you don't do very much, you just go, you visit, you say, how are you doing? And, you know, they're feeling sad, but it helps them to talk, right? Talking is effective therapy for this. So just talking to you or talking to the CHW, talking to the nurse is appropriate. And in pediatric palliative care, we have the same definition as adult palliative care. You know, it's about holistic focus on treating pain and symptoms and psychological, social, and spiritual concerns. But really in pediatrics, we think, okay, how can this child live and enjoy life as much as possible, whatever the limitations are on their life? They really value having connections to their family and friends. So children get very lonely in hospital. So it's very important, if you don't think you can cure the child and they could be managed at home, that we transfer them home. They love being at home. They think it's a safe place, and they don't like being in hospitals. Hospitals are very scary for children, much more than for adults. Adults know why they're in the hospital. They can kind of accept it on some level, but children, it's just very, very anxiety provoking. And children want to be with their parents or whoever is their primary caregiver, the people that love them and look after them. And we should think about the activities we can do for the child or with the child, or that the child can do, like playing, songs, arts and crafts. All of these are really good to do so the child can really have fun, enjoy life. Right? It's not complicated stuff for children often, as long as we manage their symptoms first. So Dr. Natasha in her video talked a lot about which children need palliative care and broke them into these 3 categories. Children living with progressive conditions where there's ongoing deterioration of health and or abilities. Children living with life-threatening conditions. So you don't have to know for sure the child's going to die. It's like if you're worried, you think this is quite life-threatening, that child could qualify. Okay, and I would emphasize that the studies that have been done in children's hospitals in low and middle income countries that have looked at all the children in the hospital, they've done some studies and said, does this child need palliative care? Typically, it's 40 to 60% of the children who are in a hospital. Okay, it's very high needs because children are in hospital in low income settings or low resource settings because they're really sick and lots of them die. So lots of them need palliative care. They don't all need specialist palliative care, but they need a palliative care approach. And we'll talk about what that is. And we've been talking about it in the course all along. And then third category where we get involved is children who have significant pain or other symptoms, which palliative care can address. So for example, not that common in Bangladesh, but children with sickle cell disease. They have so much pain and palliative care gives expertise in pain management. So often we help those children. Even though maybe the child doesn't have a life-threatening or life-limiting illness, we need to also help those children with their symptoms. A few of the other examples of children would be, these kinds of different conditions. So cancer, congenital anomalies, neonatal conditions, HIV/AIDS, not that common in Bangladesh, but it's something to mention, congenital heart disease, cerebral palsy, metabolic and other genetic conditions. And I would emphasize that you don't need to know what is the exact condition because they all don't really have any treatment, right? There's very limited treatment options. And then advanced kidney, lung, or liver disease. And here is a graph that shows if you look at all the children who need palliative care in the last year of their life, what was the condition that they had? And this is in the whole world. And there's about 1.2 million children here who in the last year of life are estimated to need palliative care. And the biggest groups is neonatal conditions and congenital anomalies. So that's like any baby born with anything quite significant that needs surgery, that's very difficult to fix, or any child who's born premature. Often those children all are ones where you really need to consider palliative care. And we think about what's a palliative care approach? What's our framework? How do we think about these children? What's wrong with them in pediatric palliative care? So I think about them when I see them for the first time in these 5 different categories. What are their physical problems? Do they have pain? Do they have other symptoms? What are their emotional problems? And I don't just say, oh, like, what's their psychological problems? I think, how are they happy? Are they sad? Are they worried? What are they worried about? What are the social things that are important for them? How is their family managing? Do they go to school? Can they go back to school? Because school is very important for children. It's like normal. They like going to school. They like seeing their friends and their whole community, right? The illness doesn't just touch the child. The illness touches the whole family and community when the child is very sick. And the spiritual needs of the patient and the family, especially because I often question, why did this happen? Is God punishing us? Is it because we didn't do enough prayer, or is something bad that we've done? So we have to help them answer those questions and know that there wasn't something that they did wrong. And then lastly, we think about trajectory. Trajectory means like what's happening in the future. So we plan for the future and for possible end of life. What's going to happen if the child gets sicker? What's the plan the family has? Are they going to stay at home and make telephone calls, have visits from CHWs or doctors and nurses, or are they going to bring the child back to the hospital? And both are acceptable options. It just depends what your resources are and what your plan will be. But it's better to plan so you have less crisis. So this is about the palliative care approach. So we know that we are not all going to be palliative care specialists, and this is a tiny fraction of the children who need palliative care who need the specialists. Most of the children can benefit from what we call a palliative care approach, which is delivered by primary care physicians, family medicine physicians, pediatricians, adult palliative care physicians, nurses, social workers, counselors, psychologists, and every member of your team can be included in this. And the training that we give you gives you the tools to do a palliative care approach. And it's really about teamwork. All these people can be involved and can help the child and their family. We each have a different role depending on what our skill set is, what our specialty is. We have physicians, we have the coordinators who help us organize and make sure we see the patients on the right day, keep track of many things. We have physiotherapists, we have speech therapists potentially, community volunteers, palliative care assistants, which are a special type of CHW or community health workers who can be trained up to care for patients at home, and nurses. And some of these we've put the word part-time because they can have this role in addition to having other roles in the hospital or clinic or wherever they work. And Dr. Natasha then shared with us some practices, some ways, tangible ways we can change our own clinical care to help children and families. So a few key points I would say is think about the needs of parents. So things that are helpful for us to say to parents. Tell them that we know that they know the child best. So say, I know you know your child best. What do you think? Do you think she's in pain? How is she doing? What's important? Tell them that they are good parents because they feel very guilty often. They think they caused the illness. They think they waited too long to bring the child to the hospital. So just reinforce that they are loving, they are good parents, they've done the right thing because after the child dies, they have to live with all those feelings. So it's important to support them. Give them clear and honest information. And we talk more about this and why this is so important. And give them that information in a way that is caring and sensitive. So we want to share with them gently, but truthfully what's happening. Make sure that they trust us. So develop that relationship with them so that they trust you, because the more they trust you, the more they will let you give good palliative care. And if the child's going to die, tell them that before the child dies, because parents say this is very important. We need to tell them earlier. They often feel they're not warned. What about the children themselves? So that was the parents, this is the children. They need reassurance that they know that they will be looked after and loved and not be alone. So the biggest worry of children is that when they're dying, they will be alone. So this is very easy to fix. They all have parents usually. So we just say your parents will be with you. You always let the parents stay with the child or the primary caregiver. And you encourage the caregiver to show love and nurturing attention. So just cuddling the child, holding them, being with them, talking to them, singing to them. These are very important for children. Children need simple, honest, and age-appropriate information. We'll talk more about that, and they need to be able to play. So we need to give toys and opportunities for play, art, music, stories, that kind of things. So these things seem like extras. They seem like not important. They don't seem like medicine, but they are part of medicine for children. So let's talk just very briefly as I'm wrapping up about communication. So we know that it's important we communicate with parents and tell them what is their understanding of the illness. We ask that, and then we take permission to share. Research shows that parents want clear and honest information about prognosis. And we often use this phrasing in English: I wish, I worry, I wonder. So here's an example. I wish that things were different, but I am worried that your child is very sick and the medicines that we have are not going to make him better. I wonder if we should plan for that situation, that he doesn't get better. Okay, so this is a way to gently say that things are not going well. That's your first sentence you might say. And then you're going to build on that and say more about what's going on. So this is just an example of the first sentence. This is a very important slide because most people think that if we give honest information, then people, children, families will give up hope and the child will die sooner. But we know that's not the case from the research. So we know that if we give honest information, people have the same amount of hope. Okay, so this is a study from Boston where the doctors looked at how much hope the patients felt, it's adult patients, before they got the true information about their cancer and after. Okay, and they have some surveys called the Hearth Hope Index. They ask the patient a bunch of questions. They get a score for how much hope the patient has. And the score was 42 before, and 42.8 after. So these are essentially unchanged. And in between these two hope indexes, the patient was told you have cancer and this is the percentage chance that you will survive. It was very clear and honest information. I want to show you some pictures in the last couple slides of the children that we care for in Coral slum in Dhaka who need and receive palliative care. And it's showing just that they get pain and symptom management. This is Dr. Noor Jahan, one of our doctors, a pediatrician who goes and visits part-time and helps us know how to manage the patients. Some of the children get speech therapy with a speech therapist. They get some physiotherapy to support them. And this is a CHW called the PCA. The PCAs are always in blue. That's their uniform. She's helping the child with the physiotherapy at home. And then they get play therapy and cognitive development support. We have a tiny little play corner and the children come and they can play games, they sing songs, they interact with the CHWs in this small play corner. And you can do the same thing at home for the children or in the hospital. We also give a lot of social supports because the families are not that well off. Medicine, food bags, financial support for diagnostic tests if they have to go for more treatment beyond our program. Rehabilitation support, if they need it, they can go to a special rehabilitation program for several weeks. And we give gifts for festivals, winter clothing, blankets. We support the siblings' education, etc. So many things that you can do that are non-medical, but sometimes make a very big difference for these families. And then other supports include emotional support that we provide, spiritual support, bereavement support, and training. There's family caregiver training, and there's residential rehabilitation training program for sick children and their mothers who have cerebral palsy. So in summary, we have to be willing to be open and honest with families to help them understand their child's illness. We have to use an integrated approach, meaning we integrate palliative care early in the illness, like that picture I showed. And then we have to use good pain and symptom management to make sure the best treatment for the child and their suffering. So I'll wrap up there. Thank you very much.
Super, thank you, Megan. That was very clear. And there was one figure that stuck out in my mind there, that 40 to 60% of children in low middle income countries in hospital would might benefit from palliative care. And that's, you know, while we know it's high, I didn't actually realize it's quite that high. So that's just a reminder that we should be thinking about palliative care for our children in hospital setting. So we have one question in the chat, Megan. There's a question about if pharmacists have any role in pediatric palliative care. Do you want to just answer that one?
Yes, they definitely do. And I apologize, pharmacist is not on the image. I didn't make the image. I copied it from the BSMMU team. So I couldn't change it, but definitely you need the pharmacist because they help so much with getting the medications, preparing the medications, counseling about the medications. Yeah.
Thanks, Megan. Does anyone else have any other questions or any clarifications for any of the information in Megan's presentation? While you have a think about that, do go ahead and write them in the chat if there's anything that wasn't clear or anything you want to ask about, or if you have any questions about a child that you've been caring for, feel free to ask about that as well. We have the benefit of Megan, who's the pediatric palliative care expert here. So do feel free to bring forward any questions, even if they're not about the presentation directly. So I'll just give you a couple of minutes to think about that, and do write in the chat, or feel free to unmute yourself and ask your question. Ask your question verbally. Okay, so we have, thank you, Erin. How do you introduce yourself to families about what is palliative care, especially with limited knowledge? How do you say who you are or what your team does? So thank you, Erin, for prompting that question. So Megan, do you want to say something on that?
Yeah, so I'll say two things. So probably in most of the settings, you're not going to have a separate palliative care team. Probably you're going to have your pediatric team who you just give a bit extra skill training to give them pediatrics palliative care skills. So they're not going to necessarily formally introduce like a separate team. So if it's just like, okay, our approach is going to include palliative care, then you may just explain, okay, so palliative care, this is what it is. It's care for children who are seriously ill, children who have life-threatening or life-limiting conditions. And some of the most important things is focusing on quality of life, making sure we manage his or her symptoms, including pain, other symptoms, and how is the family coping, and supporting the whole family. So that's my sort of generic piece there. And then if you have a separate team that's going to come in, or a separate person, or you're going to, refer the patient or the family to somebody who's going to be more involved, then when I come as like the specialist, I explain that same kind of thing. I say, this is what I'm a pediatric palliative care physician, and this is the type of children that I see. I see children who have very serious illnesses. They're sick. They might be sick for a long time. They have complex illnesses, and we're worried that they might not get better, or they might get sicker. And then I say, my focus is going to be on making sure we support your whole family. All the people in the family are affected by the illness, especially the parents who I'm usually talking to, and then making sure she's comfortable, he or she's comfortable, they're not suffering, they're having good control of pain and other symptoms. And it sort of depends on also what I know already is happening. Like if the child's already having a lot of pain, I might focus on that. And I'll introduce ideally my team who comes with me and say, okay, our team is a doctor, a nurse, a counselor, and here's what the nurse can help with. Here's what the counselor will help with. We will see you every day or every week or whatever the plan is.
Thanks, Megan. So that's really helpful. So being honest and clear about who you are, what your role is, and how you can help. That's what families and patients need to know, how you can help them. Super. So I don't see any more questions at the moment. Please do continue to write any questions or comments in the chat on anything related to pediatric. And what we'll do now is today we're going to have a case presentation. I'm just going to turn my video off because my internet's a bit unstable. Sorry. Today we have a case presentation from Dr. Junaid and Rachel, who are both working for MSF Spain in Gayolmara Hospital, which is just outside the camp setting. And I'll hand over to you now. Thank you.
All right, excellent. Catherine, are you going to share my screen or should I share from my side? Just wondering. Oh, there we go. I see it coming.
Hopefully you can.
I think I see it coming. There we go. Perfect. So maybe while the screen is coming up, can you hear me okay? Just want to confirm.
Yeah, we can hear you.
Yes, I can hear you, Rachel. Sorry, that was my internet connection.
Oh,
yeah. Can you see the screen?
Perfect. Yes, I can. All right, perfect. So yes, so my name is Rachel. I'm the nursing activities manager in the neonatology department at Gayolmara Hospital, which is just outside of Camp 16 in the Rohingya camps. And I'm going to sort of give most of the presentation just because several of my colleagues aren't 100% sure about their internet connections, but I have several colleagues here on the call, including Dr. Junaid, who's one of our one of our doctors and our palliative care medical focal point. I also have Fastly, our mental health supervisor on the call, and Johnny, who is our member of our health promotion team, and Lara, our pediatrician, as well as a couple of nurses, I believe, are on the call, including Kulsum. So I just wanted to thank them all for joining us. I'll leave a bit of time at the end for them to add any thoughts, but I'll go through the slides first. All right, can you go to the next slide, Catherine? So I'm going to share today about a case that child that we took care of back in April and May. And I just wanted to share at the beginning that this is we're sort of getting started offering some palliative care in our project. And so this was one of our the children that we were sort of trying to be more formal about our approach. improvement, but we really are looking for your input and thoughts. So thank you for that. So some of the questions that I was wanted to propose for discussion were, first of all, what is the best approach to managing an acute and potentially reversible condition or deterioration in a child who ultimately has an incurable condition underneath? The second question was, how could we better manage this child's breathlessness, especially since morphine at the time was not available? How could we have supported this family's preference to take the child home, given that she was dependent on oxygen? And any other suggestions around that request? And what is the best approach when a family requests to see a traditional healer while hospitalized? We're also just open to other suggestions. All right, next slide. Catherine, can you switch to the next slide? So
Sorry,
our little
I'm just a little bit problem with my connection, and we'll get there.
Oh, okay, no problem. I'll keep talking and it'll eventually switch. I think I know the slide. So the child that we'll be talking about today is a 5-month-old little girl, and she was diagnosed with congenital heart disease, specifically transposition of the great arteries. She was admitted, if I remember correctly, on April 24th, and she was also diagnosed with, I'm just going to look at my other, she was also diagnosed with severe acute malnutrition, bronchiolitis, and septic shock. Maybe we can switch to, to the next slide, actually. I wonder. Megan, do you think, would it be easier if I shared from my side, maybe?
Yeah, do you want to try and share?
Yeah, I'll see if I can.
Oh, Catherine started again. Hold on.
Oh, there we go. I see it now. So actually the next slide, if you can, Catherine. Here we go. Perfect. So this child was with us for quite a while. So I'm just going to sort of quickly go through a bit of a timeline so you have a sense of what we did for this family. So the child was admitted on April 24th. She came in, the family reported to us that they had been trying to seek care at several other hospitals and the child wasn't improving. So they came to us. She was admitted initially with fever, severe respiratory distress, and diarrhea. At the time, they noticed a heart murmur in the aortic region, and she also had pretty significant hepatomegaly. She was having quite severe respiratory distress and hypoventilation bilaterally in the lungs. And so the team was actually, and wheezing. So the team was actually suspecting bronchiolitis, but with a possible underlying heart condition. So at the time they started oxygen by reservoir mask at 10 liters per minute and gave antibiotics, dexamethasone, salbutamol, and IV fluids. Over the next couple of days, just to mention that when the child first came in, she was very, very critical. And they were concerned about her survival, I think, at that point. On the 28th, her condition was improving and somewhat, and the team had been able to wean her oxygen down to 2 liters by nasal cannula, but she was still having moderate respiratory distress. That day, the team did a point of care ultrasound, which we have available at the hospital, and this revealed transposition of the great arteries. And the team was able to send the images to our telemedicine team, and they confirmed that diagnosis. At this point, the team was giving feedings by NG tube with Formula 1, and each day was sort of increasing the amount of feeding based on her tolerance. So on May 2nd, the child was becoming more sleepy, but she was still opening her eyes and moving around, having some periods of irritability. She was continuing to have this moderate respiratory distress and was oxygen dependent. In order to maintain a saturation, even to get her saturation up to 85, she required oxygen. But generally her condition was improving. At the time, the family was asking about going home, and so we were looking to see about the possibility of offering morphine to her because of the breathlessness, but we didn't have anything in the project. So We did send a prescription to DACA to see if we could get morphine, but it hadn't arrived at that point yet. The family at that time agreed to stay in the hospital because they felt that the morphine would be helpful for the symptoms. At this point, we also decided that given her underlying condition, in the event that she had a cardiorespiratory arrest, that we wouldn't offer CPR. We weren't entirely sure at this point about her life expectancy. We knew that she had, we had looked into possibilities of referral to another facility, but this is a Rohingya family, and we have basically 2 referral options, and neither was willing to take a child this young for the surgical repair. So that was the situation at that point. Catherine, can you go to the next slide? So then on May 4th, the child had a sudden deterioration. She developed fever, really persistent fever, severe respiratory distress. Her saturations were dropping again and having prolonged capillary refill time. She had, I mentioned fever twice, tachypnea and an elevated white blood cell count. So the team was thinking that she might have developed septic shock at this point. And there was quite a discussion among the team of whether or not we should aggressively treat the septic shock or not, but we felt that it might be reversible. So we gave fluid boluses, restarted antibiotics, and increased her oxygen back to 14 liters by reservoir mask. After this point, the child's condition just progressively deteriorated. So on May 4th, after consultations with our palliative care advisors and our pharmacist, the morphine still had not arrived. So we decided to start tramadol, which is not recommended for a child this young, but we didn't have an alternative. So we started her on tramadol, fairly low dose, but it didn't really seem to be any improvement. We decided to continue the medication. At that point, we made a decision that if the child, if she did, we were able to wean the oxygen a little bit. So we decided that if she were to worsen further, we wouldn't sort of re-escalate the oxygen. She also had a convulsion the one night, but it stopped before we gave any medication. And at that point, we made a decision that if she were to start having to have any convulsions at all, that we would aggressively treat with diazepam. She had another convulsion then on the 7th that we treated with diazepam. By the 8th, her Glasgow Coma Scale was dropping, and she was becoming more sleepy and obtunded. And then by the 9th, the family requested discharge to go home. I'll talk a bit about some of her symptoms. So the main concern of the mother was the breathlessness, and just generally that the child's condition wasn't getting better. For that symptom, we tried tramadol initially at a low dose and increased to 0.75 milligrams per kilo per dose on the 9th. We considered diazepam, but there didn't seem to be, we were thinking that it was mostly useful if she was agitated and that was contributing to the breathlessness. So we didn't give it for that indication. We used positioning and early in her course some chest physiotherapy. Another problem was fever. She had really persistent fever after the May 4th. So she was on scheduled doses of paracetamol and ibuprofen. She was occasionally irritable, and we thought about giving diazepam, but we never used that. Convulsions, but we did use diazepam. And then there's a possibility of pain. It's hard to know. Given her, she was very sleepy, but she was having issues with skin breakdown and phlebitis from IVs. So that was part of the reason for those medications. All right, next slide. So a couple of nursing issues. So I spoke to the team that took care of this baby, and the 2 main issues were, first of all, that IV access was becoming quite complicated for this child. She was getting a little bit edematous, and just after such a long admission, getting an IV was getting difficult, and she developed a phlebitis in one of her hands. She also had some skin breakdown she was having a lot of loose stools near the end, and developed a bit of skin breakdown in her perineal area. So we were using zinc oxide and sort of frequent diaper changes for that. Next slide. Psychosocial concerns. So I spoke with both the health promotion team and the mental health team who were very involved in this case. So the mother and paternal grandparents were quite involved in the care of this child. The father was never really involved. We believe that it's probably because he was caring for their other child. They have one older male sibling at home. But they weren't 100% sure. This is a Rohingya family from the camps. Their primary concerns were around the child's breathlessness and just generally like, what is the cause of this disease? Why isn't she improving? And why weren't we referring? Even some of the staff had questions about why MSF wasn't referring the child elsewhere. Unfortunately, there wasn't an option to refer. We looked into it quite a bit. When we initially disclosed the diagnosis and prognosis, the mother was very shocked and quite emotional. Initially they were asking to go home, but once our team spent quite a bit of time explaining that we would be able to better manage her symptoms in hospital, they decided to stay until the last day. The family said that when they decided to go home, the main reasons they explained to us is that they needed to help care for the other child and that they had been in the hospital a long time. The mother had 3 sessions with our mental health counselors that were quite valuable. And I think basically daily visits from our palliative care coordinator who's on the call here. We also allowed open visitation and we made sure that the watchman of the hospital knew that this family could have any visitors come in that they needed. Next slide. Spiritual concerns. So this is a Muslim family and their faith is quite important to them. At one point, the family requested, they said that they wanted to go home to see a traditional healer. And so this was one of the first times we did this, that my colleague Johnny was able to facilitate a visit by the traditional healer in the pediatric ICU. So what he did was he spoke first with the traditional healer just to make sure that the person understood that the agreement was that he couldn't give any sort of internal like medications for the baby to take orally. But the person performed a zarfuk, which Johnny explained to me is he read a passage from the Holy Quran and then blew on the baby as a way to sort of bless and try to promote healing for the baby. The other factor was that the baby was discharged on May 9th, which was right before Eid, and the family wanted to go home and celebrate together. Next slide. So communication. So when the baby first came in on April 24th, at that point, the child was critically ill. We didn't know the situation. And so the team did speak with the family and explain that the child was critical. And at that point, asked permission to give CPR if the child were to have a cardiorespiratory arrest. Later, we decided that wasn't appropriate. And we changed that decision. But on May 2nd, we had a sort of formal family meeting with the palliative care medical focal point, myself, the mental health counselor, the palliative care coordinator. And we sat down with the mother and the grandparents. The mother was very much wanting to go home, but the grandmother felt that she wanted to stay because she was concerned about the baby's symptoms. It took quite a bit of explanations, but we were really fortunate that the doctor and the palliative care coordinator speak Rohingya, which made them better able, I think, to develop what I call like therapeutic rapport. Like they were able to have an actual person-to-person connection. And the doctor used some drawings to help explain the baby's heart condition. It took a while for them to understand what was happening, and sometimes they would require repeated explanations. But in the end, they did understand that the child had a hole in her heart. They were able to verbalize that to us. They did have a lot of questions about why we weren't referring and had asked repeatedly, they thought MSF has a lot of money. Why aren't they paying for this surgery? So that was a difficult thing to explain. Next slide, please. So I think the next one is about, collaborations and partnerships. So there was a lot of people involved in this care. First of all, the palliative care coordinator and other members of our health promotion team spent a lot of time explaining things that the medical team had already tried to explain in a more understandable way. Mental health team, the medical team, obviously the physician and the palliative care focal, like the treating physician, as well as the medical focal point. Nurses, health assistants, our medical translators, and nurse manager, myself. The MSF telemedicine team was really valuable in sort of confirming diagnosis and giving recommendations, as well as our specifically the palliative care reference on the telemedicine. We did consider potentially home-based care through one of the other partners in the camps, but one of the challenges was that the child was on oxygen, and so we weren't quite sure if that was an option. All right, next slide. So just a brief summary. We had a 5-month-old little girl with transposition of the great arteries, also diagnosed with bronchiolitis, severe acute malnutrition. The primary concerns were related to breathlessness, oxygen dependency, and then the family wanting to go home in that context. The case was complicated by the fact that at the time we didn't have morphine in the project, and then the child developing a septic shock on day 11 of admission. So that is the end. I just want to invite my colleagues on the call, like especially, well, any of you, but I'm thinking of Junaid, Laura, and Johnny. Do any of you guys have anything you would add to what I've said?
Hello, Rachel.
Hi,
This is Fazli. Yes. So I think you explain everything from the mental health side of what you did in the project. My point of view is like the emotional support of the mother. This is the most important on that time.
Yeah.
So from the mental health side, we always like to be care and understand about the situation. And what is the difficult thing for the palliative care is the scenario change frequently. Like the morning, the scenario, and the afternoon, the scenario is very different. And no, it's depend other patient, the caretakers who are nearby, their impact also. No, because if they show some negative something in the hospital, some patient died or some critical movement in the hospital, so those has also impact of the caretaker's mind. So you know, it's very challenging of the emotional stability of the caretakers. So like in the morning and in the evening, so we like to be very careful. In the morning we have a session, we try to be the session in the very beginning of the day, and at the end of the day there we try to be around the patient, like okay, did the patient is the caretaker is okay or all right, or something happens, so some changes there. So these are the thing. And I think from our side, we do our best for the emotional support for the patient.
Thank you so much for that, Fazli. Actually, that might be a helpful question for us to invite with the group is we often have a challenge where we recognize that seeing the rest of the families in the department are quite negatively affected sometimes when they see another child dying, but we've noticed that a lot of our patients who need palliative care prefer to remain in the PICU rather than in a separate or isolation room we have used for palliative care. Do you want to add something?
Hello.
Hi, Dr. Day, please go ahead.
Yeah, okay. I am Dr. Junaid, working as a medical doctor and palliative care doctor in MSF Guelmara Hospital. So, thank you, Rachel, for this nice presentation regarding the child that we have discussing. So, first of all, when the patient came to our facility, we were trying to manage the acute emergency symptom like the shock and the other medical condition. When we confirm that it could be a case of TGA, then we are trying to start counseling with the family. Every time we are facing the problem like when we are trying to convince the family that we are going to start the palliative care, the most problem that we are facing that the mother asking why this is a case of palliative care and what is the palliative care and why we were just stopping the other treatment. And I think it is a difficult point to us to convince the family, like the whole palliative program. So in that case, we are making every day we are with the help of the mental health team and social team and health assistant to convince the family. This is not the first case that we are facing problem. Each and every time, with a few days later, we are receiving some patient with this type of illness. So we are trying to do our best. And another problem we are facing regarding the possible referral. Though it is not possible for us to refer this child, and the patient does not fit the criteria for a referral, and she is on oxygen dependent. So I think the medical care we are giving, that was our best option for this child, and that's it.
Thank you. And thank you, first of all, Rachel, for such a thorough case presentation. I think you described both the issues and your management of the case in a lot of detail. It can be, I think a lot of questions have come up. You've put your own questions there, and we've had a couple of additional ones as well. But just to say, breathlessness can be a very frightening symptom. For the patient, for family members, and also for staff. It can be really difficult for seeing people with breathlessness and distress. And I think you should recognize that this would be a difficult case in any setting for any group of healthcare professionals. This is not easy to manage a child with this condition at end of life. And I just wanted to first highlight a couple of things that I think you did really well. And then we'll open up to the faculty to start thinking about some of the questions that you've brought to the group. So I just wanted to say that the multidisciplinary team working seemed to be excellent. You had involvement of the different teams within the hospital. You were available and gave a lot of support for family from the presentation. You were communicating very well with the family and throughout the time the child was in hospital, and you were focusing on symptom control. So you have thought about all the aspects of palliative care, which is really excellent. And I think that's the first starting point before we discuss the case in more detail. So shall we think about the questions? So we've got the questions that you've put forward here, and also to think about it being distressing for others on the ward, and how do we manage when families say, why only palliative care and why not referral? So there's lots for us to think about. So let's start thinking about some of these questions together. So the first one is, what is the best approach to managing an acute possible reversible deterioration in a child with an incurable condition? Megan, do you want to say something about that? Or...
Yeah, I can say something about that. Hold on, I've got an echo. 1 second. Okay, so I would say this is the gray zone, right? So you have sometimes it's clear you should just provide end of life care. There isn't treatment that will help the patient potentially return to a better state of health. And sometimes it's very clear that there is treatment and you should do it. It's very clear, but most of the time it's in the middle. So it's hard to figure out. And you just have to do exactly what you did, where you talk about it many times, and every day or even twice a day, like Fazil was saying, you reevaluate the situation and what's appropriate for the patient. And every time you're making a decision based on the best information that you have, which changes, right? At first you didn't know the child had TGA. Then you find out the child has TGA. It changes your approach to whether you think this child would benefit from intensive resuscitation. It was a good decision when you change that, because at first you didn't know. You thought maybe it's a healthy kid. You can resuscitate healthy kids sometimes. then okay, they've got TGA. Child with TGA, like, I think don't be over optimistic. Like, this is a really sick child baseline. I think you did well to keep them as well as possible and not over treat them. But the main thing is to just decide every day, okay, are we still on the right track? Is this appropriate? And just think through, if we do this, what is the potential benefit for the child? What's the potential harm? Are we causing suffering? Are we making a good decision that supports the child and their family and the sort of holistic quality of life? And it's okay that you take most of that decision on yourself. Okay, so some input about the family's perspective is important, but this is very complex medicine. This patient's in the ICU. You're giving like intensive care. Families cannot understand that fully. So there is always a level of, we have to kind of present it in a certain way and get guidance from them. But you can't be like, do you want inotropes or not? Do you want me to give a bolus or not? Do you want me to give a transfusion or not? It's big picture, right? Is this appropriate? Is this good to continue? But yes, you can manage an acute, potentially reversible condition in a child with an incurable condition. But you have a limit to what you would do.
Thank you, Megan. Do any of the team have any questions further about that point, or any other comments? So we'll move on to the next question, which was, how could we better manage this child's breathlessness, especially since morphine was not available at the time? Now, I was involved in discussion with you, Rachel, I remember at the time, about how we manage the breathlessness. And I remember it was a bit of the case was a bit of a prompt to help you as a team realize, actually, we need opioids in our project, which it was a bit unfortunate for this child. And while you had tramadol, you didn't have access to morphine. But I think this case, correct me if I'm wrong, but I understood this case really helped you as a team realize that morphine was an essential drug. Is that fair to say, Rachel, would you say?
Yeah, I think it was also, unfortunately, for this baby, she arrived right around the time when we had sort of figured out a pathway that might work. But I do think it's sort of more urgent, if that makes sense, that we act on that pathway. So,
and one other, and I'll hand back to you, Megan, for this, since it's your expertise, but one other option that we might have had to use earlier would have been sedation. So sometimes when we have a really difficult symptom, we can use diazepam. We use diazepam for breathlessness or for any symptom that is distressing and overwhelming, to essentially to sedate, to decrease conscious levels so that that person does not suffer from that symptom. And I think that potentially was one thing we might have done earlier for the breathlessness. And it's easy to say that when you look back, because I think at the time, it's whether you as a team recognize that actually this is end of life, this is last days of life, and this is irreversible. And I think that was part of the discussion in the team, as I remember, that diazepam to sedate to manage the symptom, but at that point you sort of accept that this is sort of end of life care. Megan, do you want to say anything more about the management of breathlessness in the absence of morphine?
Yeah, so I think that if you don't have morphine, then just treat with benzodiazepine, like straight away. Low dose for anxiety, right? Because breathlessness is so anxiety provoking. So just go straight to that. I might not have used tramadol just because baby's so small, and I probably would have had the same experience as you, is like, not sure if it's working, titration is difficult. But again, I wouldn't say it's the wrong approach. It's just, people have different approaches, but over time with experience, you might feel like, okay, we don't have morphine, then we're going to go for diazepam, regular intermittent low dose, or IV dosing, whatever you have. I like midazolam, injectable midazolam, just putting a little plug out there for it, because it's shorter acting, so you can titrate better. And if the patient is acutely looking more distressed, and you think they could benefit from an additional dose, then you can give a dose. It'll last, much shorter period of time. So it's available in Bangladesh, Dormicum. So it might be something to have and get your team a little more comfortable with. It's just a bit more flexible to use, because diazepam is quite long acting.
Thanks, Megan. And I think it is on the essential drug list, so it should be easily authorised in MSF. So the next question you have is how could we have supported this family's preference to take the child home, giving her dependence on oxygen? Do you want to say anything more about that as a team, about what your dilemma was?
Yeah, I think, I mean, I'll give the rest of my colleagues a minute, but yeah, I think one of the challenges we also faced here was that the child by this point was not able to swallow. And so we were, even if we had oral morphine, we were sort of not sure, like we considered the possibility of sending her home with an NG tube so that the family could give oral medication that way. But basically our medical coordinator didn't feel comfortable and we didn't think it was the best idea. So it was partly, we recognized that once we, if she was at the end of life, then just removing her from oxygen was an option. But in terms of managing her breathlessness also at home, given that we don't really have, we have people that could do home visits in certain camps, but not in the camp where this family lives. So it would have been only like telephone follow-up. So that was one of our challenges. You guys can add anything though, if, I guess, well, just one thing Megan was just asking, did the baby live after discharge? So unfortunately, by the time they went home, my understanding is that the child died very quickly after going home, potentially even on the way home, because they left when she was, very close to end of life.
That's probably okay. Like, I know it sort of seems kind of scary for some of us to think, oh, my child passed away like on the way home, but we have lots of families have that experience in India, and seems to be okay for them. Like it's acceptable. They consider it to be sort of an acceptable scenario. So, and I'm sure you have that experience in the camps too. So it can be okay. It's very important for the family to feel they did the right thing. So that can be part of them feeling that they did the right thing for their child.
Just a question for the team. Would you have done anything differently if you were doing this again? Would you have thought about discharging home sooner? Now, I ask that because I know it's very difficult without morphine or without giving any medication for the distress. But would you have done anything differently if you were to do the same again?
I might leave that for my team. Do you guys have anything you would do differently?
And I think some of it comes down to confidence as well, because it's not easy to sedate a child and render them barely conscious and send them home. It's not an easy thing to do. And it's not easy to send a child out of the hospital breathless easy. So it's really not an easy case to manage. I don't think that there's, you might have thought about when the family wanted to go home sooner, you might have thought about that. But I think in the absence of using morphine and without the confidence of sedation, it's not an easy decision, or it might be that you would do the same again and keep the child in hospital even. I'm not asking you because I think you should have done something differently, but it's just thinking about next time.
I think one thing that since it doesn't seem like they have anything to add right now, one thing I've been thinking about is, and I don't necessarily think in this case, this was a big issue, but as you were saying, like the family needs to know or think that they are doing the right thing for their child. And I think sometimes we, as a team, we really try to encourage the families to stay, because that's sort of been our pattern in the past, and we don't have we're working on our follow-up options. But just making sure that we're not making families feel guilty when they leave. If they make the decision to leave, that it's a supported discharge, that they are going with our blessing, so to speak, that they feel like they're not making the wrong decision. I think that's something we can work on. And we do have phone follow-up options from our team. So now our colleague Johnny is making phone calls to families, bereavement follow-up phone calls. And in certain camps, we can actually do a home visit follow-up at this point.
Thanks, Rachel. And I think it is very difficult for the team to sort of see a child that's symptomatic and let them go home.
Yes.
But one way around it is to say to the family, look, here's our phone number. If you have any difficulties, call us. If you have these symptoms or things are difficult at home, please do come back. You know, we're always here and we'll come back at any time. So try to give a safety net as best you can. So the family know that it's not a one way, or we chose to go home and we can't come back. They can always come back.
Yeah, that's great. Yeah.
The next question is, what is the best approach when a family requests to see a traditional healer? I'm just wondering if one of our other faculty might want to answer this. Erin, do you want to say something about this?
Yeah, I thought the way that you guys handled this situation was actually really quite spiritually and culturally very sensitive, because I think sometimes when we are in situations and families are looking at traditional healers, sometimes we have the sense that it's one way or the other. So I thought the way that you were able to incorporate inviting the traditional healer into a more I guess the hospital, the modern medicine, I guess you would say. I thought that was really, I've actually learned from this case presentation that could be possible. And I think it was also very humbling of the traditional healer to agree. I think when you had said that they agreed they wouldn't put anything, you know, inside the body, or it wouldn't ingest anything. I thought that was actually very sensitive. I don't know very many traditional healers personally, so I thought that was quite interesting, and maybe reduces some of the stigma that I maybe am putting on traditional healers. So yeah, I think it was really helpful that you were able to allow them to feel that they were able to look at this avenue of something. And yeah, I'm sure that there probably are ranges of traditional healers where people would not be maybe as sensitive or as humble as this person seemed to have been. But yeah, I think as the source of or the primary source, or the only way that we treat people, I think we need to be really careful about that. So.
One thing I'll just add on that, thank you for that, Erin, that's helpful feedback. I think Johnny was really the one leading that and did an excellent job. And I think one thing that he mentioned to me when we talked about this case yesterday or the day before was that because we have a lot of families that even, you know, with children who have a very curable condition, that if they're not satisfied with the care, they often ask to leave because they want to see a traditional healer. So it's often a challenge, and just generally speaking in our hospital. So one of the benefits I found was that it allowed us to, I think it built rapport with the family, and then they agreed to stay so that we could better manage symptoms. So it was sort of a way also of building that trust, I think, and allowing us to do some of the other work that we thought was important. So
I just had one other question about that. So it seemed like that traditional healer also did some spiritual preparation maybe for the baby. So in Bangladesh, are traditional healers also tied to like Islam, or is that very separate? Because I know in some cultures it would be quite separate from the mainstream like religion, would it not?
Yeah, I'll say the limited amount that I know, and then anyone else on the call who knows more, feel free. But so this was a Rohingya traditional healer. So in Myanmar, when they were there, they didn't have access to sort of, you know, Western medicine in a lot of cases. So yeah, it often, the traditional healers sort of blend religious prayers and things like that, and sometimes they do use other medications, or and there's also different kinds of traditional healers. I'm kind of using that term, but there's lots of different ones. I think Johnny is not having a great internet connection, but if you can hear us, feel free to add more on that.
And I have a suggestion. What we have said a lot in general, and it's a very general thing, doesn't apply so much to this patient, is we always tell them, yes, you can go, because they sometimes ask, can we go see the traditional healer? More for outpatients, for like our children who we are following regularly for cancer treatment or symptom treatment. And if they say, can we go? We say, yes, you can definitely go. And please go. It's okay if you want to, but please tell us what they recommended and what you did. And also, please don't stop the medications that we're giving without talking to us. So, and that seems to work really well. Like they respond really well to that, where they kind of know, okay, we can blend these two, but then they don't go away and stop all the things that you've started. Yeah.
And I think it was a very nice point, Rachel, about trust as well. And also it ties into what Megan just said, that the patient and family will feel listened to and heard, that they say this is something important for them, and that you're working with them to utilize the things that they recognize may be beneficial for them. So it's a really important part of trust, and people feeling listened to. So the last question we have here is any other suggestions to improve the care for this child and family? And I'll open this up to anyone in the faculty who wants to add any additional comments here about any other way to improve the care for this child and their family.
So I wonder if Rachel or any of the other team members from MSF can give us some advice about, sorry, I think this person is. I wonder if you can just give us advice. Okay, so this is a big learning case for you. So what can you say to help guide all of us if, because we're all going to face these situations in the future, what are some things you learned from this case? I think specifically about communication. What did you learn from going through this whole process of communicating that you would say, okay, next time now we're going to be a little better at this because we learned that this works, or this is how it works best? Because this only is developed in each of our settings through experience, I think, most of it. We have a framework, but then we must learn the way to phrase it for our own setup, or the pattern of what seems to work for our patients in our setup.
I'll start with some thoughts, but please, others here, jump in. I just want to give you a moment to think. I think one thing that I noticed, so, you know, in a lot of cases, unfortunately, our doctors aren't able to speak directly to the patients in Rohingya because they don't speak the same language. One thing that I think was really strong with how this case was handled was that both Dr. Junaid and Johnny speak Rohingya, and I was able to observe their conversations, not understand them, but I saw them sitting, you know, beside the bedside on a chair, eye to eye, like, you know, same level as the mother and family. And I observed that the mother was much more involved in the conversation than I sometimes see. So she was asking questions and engaging back. It wasn't just our team presenting information to her. And so I was really, I think that sort of, yeah, just realizing the benefit of being able, of the doctor being able to share the information about the diagnosis directly to the mother I observed that it was really effective. It's not always possible for every doctor, but I do think that in this case, it was really helpful. So just the difference that makes. Yeah.
So you describe also sharing and listening. So it's not a one-way conversation. It's listening and sharing and listening. Yeah. Yeah, thank you. Does anyone else in Rachel's team have any other thoughts on the question Megan posed about what you've learned and you can share with us and teach us about communication in this setting and what was effective and what worked for you?
we've had a few things interesting in our pediatric ICU recently in Kenya where they're actually involving our palliative care team a lot. And so I'm not sure, Rachel, how this will apply to your situation, but we have been doing a lot of counseling before even the ICU doctor comes in, and we are quite honest saying that we don't know the full situation of the treatment options or exactly what's happening, but we are here to support you, kind of like priming the pump for some of these really difficult conversations. And that seems to actually have worked really well. We spoke to the ICU doctor and she's like, we really need them to, be on board with the do not resuscitate. And the visits are a bit longer, but we tend to in palliative care have some flexibility with our timing. So we would spend 20 to 30 minutes before the doctor, approaches about that discussion. And then, within 20 minutes of her having the next visit where they talk about kind of these more large decisions about the treatment, they sent us a text message and said, the visit really went really well. They've agreed to the situation. And we really thank you that you made the time to spend with them before we even had that difficult discussion. And we didn't really have a lot of answers for them. So that was a really interesting thing we've been doing recently, where we like, I don't know if we did, it's like a pre-counseling before people and families have to like make a really difficult decision, but somehow it's been working. So I don't know if that's another approach where you can get a social worker or a nurse that seems to be very sensitive and being honest, saying, we don't really know, we don't have all the details of what the ICU doctor is going to say, but this is kind of what we know. How are you doing? Or, allowing for that time. And then it seems like that more difficult conversation has gone smoother.
Thanks, Erin. So you build a rapport, you build trust with the family, they feel listened to, they feel that someone cares for them before you have that conversation. So that's a really important part of the communication process. Thanks, Erin, for sharing that. It's a good tip. Now, I think probably everyone's racking their brains to think about how they might be able to improve the care of this family, because I think you did a really good job. And I think you've obviously put a lot of thought into how to best care for this child and how to best care for this family. Is there anything anyone wants to add about what may be done differently or added into care to make things to improve the care for this child, if that's something we could do in this setting? I know Evan's put a comment in about memory making. Do you want to say something about that, Evan?
So I know in our situation, we have had quite a few children in our PICU that have been either premature or, are less than 1 month, and the ICU docs are kind of recommending that they are not going to be able to manage at home or be discharged and that sort of thing. So we've been asking very difficult questions. Is it possible for them to get pictures? Is it possible for the parents to carry them? Is it like, are these things, this child is a human. Can we allow the ability for the parents to feel more human, before the child passes? And it was interesting. Some of the ICU doctors were saying that in Kenya, parents don't want that. They don't want to hold. They want us to, have the tubes and everything hooked up until the very end. And in 2 situations in less than a week, the parents actually said they really wanted it. So I'm wondering if some of this is also just us assuming people are not interested. So then maybe giving them the benefit of giving it an option. I don't know. Again, in this situation, the family was very clear that they wanted that. So they wanted to go home. So, as we take the tubes off, is there an option to get a picture with the child? So many families nowadays are taking, 1 month photos or 2 month photos and all those kind of things. And this family might never have had this opportunity because of all the medical interventions that were required. So is that something either the nurses or the primary care physicians, are we able to see these as actually a healing, an aspect that we can provide, and not assume that people will not want it. If they say no, then of course they don't want it. But yeah, I'm not sure if that's something that we could start incorporating. We do a lot of memory making for our cancer patients. like with bead therapy and things like that. But I'm wondering if this is something that we could have offered them.
Thanks, Erin. And Megan's just put a comment that memory making helps with the shock of learning that your child is going to die. So thanks for that, Megan. I'm aware we've run out of time. We've run over a bit, but I think this is a really interesting case. So I think that's okay. I just want to check if there's any burning questions that we haven't got to. Hopefully we've gone through most of the questions that were presented by the team. But if there are any burning questions, please do write them in the chat or unmute yourself now and we'll try to quickly answer them. Rachel, is there something?
Just real quick, I know it's in the chat. So there was a comment that Megan made in the chat about like why referral wasn't the best option anyways. And I'm just wondering, Megan, if you can just say a word or two about that, mostly for my team who will probably listen to this recording later, because I know that's an area they struggled.
Yeah, I think it's really challenging. So I think something that's important to have is probably for your team to have a better understanding of actually what's out there available in Dhaka or in Bangladesh in general. And I gave the advice, I think we talked about, NICVD, National Institute of Cardiovascular Diseases, is the only place these children can get corrective heart surgery, okay? And at any one time, I've been there, I've talked to those cardiologists. They're lovely. They are having 30 or 40 children admitted to the hospital waiting for surgery, and only 2 children can get surgery every day. And so we are seeing 98% of the children who need congenital corrective heart disease surgery in Bangladesh don't get that surgery. So they're going to take the children who have the best chance of success for surgery. So it's usually much older children who are strong, who have much more minor cardiac defects, VSDs, ASDs, things they can close easily. Okay, so it's a bit like the cancer situation. Yes, in the world, there exists treatment for some of these things, but these treatments are very complex, very hard to do. And, there isn't even a pediatric ICU there to support children post cardiac surgery. So if you can't come back to a ward and get normal, pretty basic care after your cardiac surgery, you really can't go through that surgery. And so there aren't Bangladeshi children who are really getting that surgery and going through that and surviving for that lesion. So I think all of the critical cyanotic congenital heart disease in our setting in Bangladesh is unfortunately not really curable, even though, yes, theoretically, if you have a cardiac surgeon who's able to do it, yes, you can change the plumbing and you can move the heart into the right place and stuff, but that's the easy part. Knowing how to fix a heart is easy. Having a health system that supports a child so that they can access that surgery is a whole other thing. It's a bit like the child with cancer who needs to access cancer treatment. Yeah, you know what the medications are that you need to give, but you need a whole system that wraps around to support that treatment to happen. And that isn't present for the children with those problems in Bangladesh overall. And then, you add the additional barrier of being from essentially a marginalized group as a refugee. So I think that I would emphasize that you're not helping by referring the child. You're actually going to harm them because they're going to go and sit in NICVD, or they're going to camp outside NICVD because they probably can't even get a bed. And so that's more suffering for that child and family. So it's a harder conversation to have with the family to say, no, we can't refer you and here's why, but to be more honest and open and have that conversation so that you understand, the family understands why it's not possible, right? It's not fair, it's totally unfair, and it's totally not a great situation, but it's the reality in so many of our settings. And this child wouldn't be a very good TGA switch candidate in any situation because they're very poorly, right? I don't think that even if you had referred them, they would have survived because they were probably already quite compromised and they weren't be optimized for surgery at the time when you referred them, right? They have to be healthy, robust, over 5 kilos, all of those things to even be considered in a setting where you have an ICU to take them to afterwards.
Super helpful. Thank you, Megan.
Thanks, Megan. I'm just going to hand over to Roshan quickly for a 2-minute summary in Bangla, if that's okay, Roshan.
Okay. Thank you, Catherine. everybody. Yes, আমরা আজকে শিখতেছিলাম যে পেডিয়াট্রিক প্যালিয়েটিভ কেয়ার সম্পর্কে অনেক গুরুত্বপূর্ণ ইনফরমেশন আজকে শিখলাম গেস্ট প্রেজেন্টেশন এবং মেঘানের লেকচার থেকে। এবং আমরা বোধহয় নাতাশার ভিডিওটা সবাই দেখেছি, সেখান থেকে অনেক ইনফরমেশন আপনারা শিখেছেন। আমি জাস্ট দুই একটা পয়েন্ট শুধু অ্যাড করতে চাই, যেটা হলো যে মেঘান প্রথমেই আমাদেরকে একটা মডেল সম্পর্কে পরিচয় করে দিলেন, যেটা প্যালিয়েটিভ কেয়ারের নিউ মডেল বলেছেন। যে রোগটা চিহ্নিত যখন হবে, জীবন সীমিতকারী রোগে আক্রান্ত রোগী চিহ্নিত হওয়া থেকে শুরু করে মৃত্যু পর্যন্ত এবং মৃত্যুর পরবর্তীতে যে শোকাহত পরিবার থাকবেন, বাবা মা বা পরিবারের পরিজন, তাদেরকে কিভাবে সাপোর্ট দেবো, এই পুরো বিষয়টা আসলে প্যালিয়েটিভ কেয়ারের অংশ। শুরুতেই রোগ নির্ণয় হওয়ার প্রথমেই হতে পারে রোগের মডিফাইং ট্রিটমেন্ট, যেটা অর্থাৎ যদি কেমোথেরাপি, রেডিওথেরাপি, সার্জারি অথবা মেডিসিন দিয়ে রোগটাকে কিউর করার চেষ্টা করা প্রথম দিকে। এবং সেখানে প্যালিয়েটিভ কেয়ার ভূমিকা থাকে, সেখানে আমরা ইনফরমেশন দিয়ে, সাইকোলজিক্যাল সাপোর্ট দিয়ে সহায়তা করতে পারি এবং টিম অ্যাপ্রোচের মাধ্যমে রোগীর কোয়ালিটি অফ লাইফকে ইমপ্রুভ করতে পারি। পরবর্তীতে দেখা যাচ্ছে যখন রোগটার অ্যাডভান্স স্টেজে চলে যায়, তখন প্যালিয়েটিভ কেয়ারের ভূমিকাটা অনেক বেড়ে যায় এবং শেষের দিকে এন্ড অফ লাইফ কেয়ারের অংশ চলে আসে। এবং সেটা হতে পারে কয়েক মুহূর্ত, হতে পারে দিন, অথবা হতে পারে সপ্তাহ। এইভাবে আমরা প্যালিয়েটিভ কেয়ার পুরো মডেলটাকে এখানে বর্ণনা শিখেছি। এবং উনি যেটা বললেন যে জেনারেল প্যালিয়েটিভ কেয়ার এবং পেডিয়াট্রিক প্যালিয়েটিভ কেয়ারের সংজ্ঞা ঠিক একই রকম। এখানেও ইন্টারডিসিপ্লিনারি টিমের কোলাবোরেশন দরকার, টিম অ্যাপ্রোচ দরকার এবং জীবন সীমিতকারী রোগে আক্রান্ত রোগী বা তার পরিবারের গুণগত মান বৃদ্ধি করার জন্য সহযোগিতা করতে হবে। আমরা এখানে আরেকটু শিখেছি যে পেডিয়াট্রিক প্যালিয়েটিভ কেয়ারের গোল কি, উনি বলেছেন যে যতটা সম্ভব রোগীকে এনজয়েবল রাখা, তার শেষ মুহূর্ত পর্যন্ত যতটা সম্ভব রোগী যেন ভালো থাকেন, আনন্দময় থাকেন, খেলাধুলার মধ্যে থাকেন, পরিবার বা বন্ধু বান্ধবের সাথে যেন কানেক্টেড থাকেন, যেখানে থাকেন যেন নিরাপদে থাকেন, সেই বিষয়টা খেয়াল করতে হবে। সম্ভব হলে তাদেরকে গল্প, গান, খেলাধুলা অথবা শিল্পকর্ম, এইগুলোর মধ্যে যদি তাদেরকে ইনভলভ করা যায়, তাহলে হয়তো বা তারা ভালো বোধ করবে। তিনটা কন্ডিশনের কথা বলছে যখন পেডিয়াট্রিক প্যালিয়েটিভ কেয়ারটা দরকার। একটা হলো যদি রোগটা আস্তে আস্তে খারাপের দিকে যেতে থাকে এবং সেটা যদি লাইফ লিমিটিং ডিজিজ হয়ে থাকে এবং ব্যথা সহ অন্যান্য যে কষ্টগুলো আছে সেটার পরিমাণ কমানোর জন্য আমরা প্যালিয়েটিভ কেয়ারটা দিয়ে থাকি। শুধুমাত্র যে ক্যান্সারের জন্য প্যালিয়েটিভ কেয়ার দেওয়া হয় তা না, এছাড়াও অন্যান্য অনেকগুলো ডিজিজের কথা বলেছেন, যেগুলোর মধ্যে কনজেনিটাল হার্ট ডিজিজের কথা বলেছেন, কিডনি বা লিভার অথবা লাং ডিজিজ, এটা সেরিব্রাল পালসি, এবং আপনাদের রোহিঙ্গা ক্যাম্পে আরো কিছু কিছু ডিজিজের কথা আমরা এই ডিসকাশন থেকে উঠে এসেছি। এবং এই প্রত্যেক শিশু হোক আর যাই হোক, আমাদের প্রত্যেকটা বাচ্চাদেরই শারীরিক, মানসিক, সামাজিক, আর্থিক প্রত্যেকটা বিষয়ের কথা চিন্তা করে তাদেরকে কম্প্রিহেনসিভ অ্যাসেসমেন্টের মাধ্যমে সেটাকে সলভ করার চেষ্টা করার কথা বলেছেন। উনি একটা পিরামিড এখানে বলেছেন, যেখানে আসলে আমরা প্যালিয়েটিভ কেয়ার বলতে শুধুমাত্র স্পেশালিস্ট প্যালিয়েটিভ কেয়ারকে মিন করবো তা না, প্যালিয়েটিভ কেয়ার অ্যাপ্রোচকে গুরুত্ব দিয়েছেন, যেখানে প্যালিয়েটিভ কেয়ার টিম সহ অন্যান্য যারা আছেন, যারা প্রাইমারি হেলথ কেয়ারের সাথে ইনভলভ আছেন, প্যালিয়েটিভ কেয়ার অ্যাসিস্ট্যান্ট হতে পারেন, অন্যান্য যাদের প্যালিয়েটিভ কেয়ারের বিষয়ে ট্রেনিং থাকে তারাও দিতে পারেন এই বিষয়টা নিয়ে। আমরা একটা বিষয় আমরা দেখলাম যে যেখানে প্যালিয়েটিভ কেয়ারের টিমে কারা থাকবেন, রোগী বা তার পরিবারের সদস্যরা থাকবেন মূল ফোকাসে, সেখানে ফার্মাসিস্টের কথাটা মিস হয়েছিল। ফার্মাসিস্টেরও গুরুত্বপূর্ণ ভূমিকা আছে। এছাড়া আমরা বলেছি যে ডাক্তার, নার্স, প্যালিয়েটিভ কেয়ার অ্যাসিস্ট্যান্ট, বিভিন্ন ধরনের স্পিচ থেরাপিস্ট, অকুপেশনাল থেরাপিস্ট সবাই এর মধ্যে ইনভলভ থাকবে। এবং বাবা মাকে আমরা যখন আমাদের এই টিমে থাকছে, তখন বাবা মা তাদেরকে আমাদের অ্যাকনলেজ করতে হবে, তারা যে একটা গুরুত্বপূর্ণ ভূমিকা পালন করছেন এবং স্যাক্রিফাইস করছেন, তাদেরকে সঠিক তথ্য দিতে হবে এবং সেই তথ্যটা ট্রাস্ট রিলেশনশিপ ডেভেলপের মাধ্যমে দিতে হবে এবং তাদেরকে তাদের যে লাভ ওয়ান চলে যাচ্ছে তাদেরকে প্রিপারেশনের জন্য সহযোগিতা করতে পারে প্যালিয়েটিভ কেয়ারের মাধ্যমে। কমিউনিকেশনের কথা খুব গুরুত্ব দিয়ে বলা হচ্ছে, বারবার বলা হয়েছে যেন এখানে আমরা অনেস্ট ইনফরমেশন দিই। এবং একটা গবেষণার ফলাফল দেখানো হয়েছে যে আমাদের ধারণা হয় যে অনেস্ট ইনফরমেশন দিলে হয়তো রোগের প্রগনোসিসে কোনো ধরনের সমস্যা হতে পারে, কিন্তু এখানে আমরা দেখলাম যে যদি ইনফরমেশন পেয়ে থাকে তাদের প্রগনোসিসের চাইতে ইনফরমেশন না পেলে যা হয়, আর ইনফরমেশনটা সঠিক ইনফরমেশন পাওয়ার পরে তাদের প্রগনোসিস আরেকটু ভালো হচ্ছে। তার মানে আমরা সঠিক ইনফরমেশনটা রোগী বা তার পরিবারকে দিতে পারি। আমাদের এখানে শারীরিক কষ্টের পাশাপাশি যে মানসিক সামাজিক আর্থিক কষ্টগুলো কিভাবে প্রোভাইড করে এটা ফরাল ইসলামের একটা স্লাইড থেকে আমরা দেখেছি যে তারা ফিজিওথেরাপি দিচ্ছেন, তারা স্পিচ থেরাপি দিচ্ছেন, বিভিন্ন ধরনের ফুড প্যাকেজ দিয়ে সহযোগিতা করছেন, ফিনান্সিয়াল সাপোর্ট দিচ্ছেন, রিহ্যাবিলিটেশন সাপোর্ট দিচ্ছেন। এইভাবে আমরা টোটাল কেয়ার দিতে পারি আর কি একটা পরিবারকে। তো এছাড়া আমরা একটি কেস করেছি, সেখান থেকে খুব খুব গুরুত্বপূর্ণ এই বিষয়গুলোর মধ্যে একটা আসলো যে যেখানে আমাদের মরফিন নাই সেক্ষেত্রে আমরা বেডলেসনেস কিভাবে সাপোর্ট, বেডলেসনেস কিভাবে ম্যানেজ করবো সেই বিষয়টা বারবার এটা এসছে। তারপর কমিউনিকেশন স্কিলের কথা বলছে, ল্যাঙ্গুয়েজ ব্যারিয়ার সহ অন্যান্য ব্যারিয়ার থাকতে পারে, সেই ক্ষেত্রে আমরা কিভাবে কমিউনিকেশন করতে পারি এবং মেমোরি মেকিং নিয়ে কথা হয়েছে। তো এই বিষয়গুলো আমরা ডিএনআর নিয়ে কথা হয়েছে এবং এই বিষয়গুলো আমরা খুব ভালোভাবে হয়তো শিখেছি। সবাই ভালো থাকবেন, থ্যাংক ইউ সো মাচ, আসসালামু আলাইকুম। That's all.
Thank you, Roshan. Thank you.
Yeah.
And a big thank you to our speakers today, to Rachel and to Megan for excellent presentations. Thank you. And thank you for your participation, for the participants and also to the faculty as well. Next week, we'll have no session for the Eid holiday. And the next webinar will be on the 23rd of July for the course 3 participants, and it will be psychosocial and spiritual support. So I wish you all Eid Mubarak.
I think there's no course on 23rd. I think we rejoin on 30th. Next week is 23rd.
Oh, thank you. Thank you, Megan. My mistake. Thank you. So no course next week, 23rd. You're on Eid holiday, as you know. And the week after will be the psychosocial and spiritual support for course 3 only, for course 3. But of course, if you want to recap, you're welcome to join in. Okay, so thank you, everybody. Eid Mubarak. Just a quick reminder that the faculty will have a very quick meeting. I'll send the Zoom link on the WhatsApp now. So Eid Mubarak. Bye.
সবাইকে
ঈদ মুবারক।
ঈদ মোবারক সবাইকে।
ঈদ মোবারক।